And now you've all been told about sort of people who don't want to be photographed. I'm going to take a photo of you. Thank you. All right. Okay, clicker works like that? It does. Okay. The impetus for this particular talk was when I went to a couple of PrEP meetings, fairly sort of high-level PrEP meetings last year, where there were a lot of physicians, and I got a lot of them coming to me with great concern saying, yeah, it's fantastic, a lot of our patients, our STI patients are starting PrEP. Equally, we're seeing a load of new people that we've never seen before at the clinics, especially the gay guys. But we're seeing STI rates absolutely rocketing, and we're really worried about it, and enough to make us wonder whether PrEP is counterproductive. This is not about the broader question of how you deal with STIs, but it is to investigate the question of whether PrEP has an independent effect on people catching STIs. We know PrEP works. This is now a famous slide, I think, from Dean Street Clinic in London, showing that HIV incidence started to tumble at the moment that the clinic decided that it would support the usage of PrEP by its patients. But what about STIs? And we're used to seeing graphs like this. The green line is gay men. And on the left you have syphilis, and on the right you have gonorrhea. The dip, interestingly, appears to be real because I've seen it across a number of countries. And I'll talk about that later. But certainly syphilis and gonorrhea in gay men do appear to be going up and maybe even accelerating. However, it's really important to realize the historical background here. STIs did not start to increase, especially in gay men, when PrEP started. On the contrary, they started when people stopped dying of AIDS. And these are charts from Europe on the left and the USA on the right, showing that syphilis, which had been almost non-existent during the 90s, suddenly started reappearing at exactly the same time on both sides of the Atlantic around the year 2000. And the first article I remember we wrote about it in aidsmap was in 2001. So it's been a long time since STI started increasing again. It's more accurate to say, that wasn't what I was going to say. It's more accurate to say they had a historical low during the 90s. Not all STIs have increased. It's really important to note that what we're talking about is two particular bacterial STIs, syphilis and gonorrhea. Rates of others have increased, but not to anything like the same extent. Chlamydia has increased among gay men, but it is, I call it the common cold of STIs. It is so common, it's so frequent, and it's so easily transmitted that actually it's the STI that is still more prevalent amongst heterosexuals than gay men, and so that tends to disguise increases amongst gay men. And other things like hepatitis C has started to go down because of the U equals U effect of the new hepatitis C medications. And of course we do also have actual success stories to tell of STIs, especially HPV. The HPV has a pretty much 100% effective vaccine, and this is a caution for when we have a vaccine for HIV. We have, and it sent HPV rates tumbling. The slide on the left are the rates that went down in Victoria State, Australia, which is one of the first jurisdictions to introduce the HPV vaccine. They went down in young men and women. They didn't go down in gay men, and that's because they didn't give it to young men. We've now learned that you have to give it to both sexes to have a true non-discriminatory immunity. And the right is recent decline in young women in the UK. It also depends on your time scale. These are historical slides. This is about sort of STIs from World War I onwards, okay? And the two slides on the right are the US and European rates for gonorrhea. US starting at World War II, just before World War II. UK starting just after World War I, and you'll see they're sort of superimposable. There was a big spike after World War II. Guess why? Soldiers are returning from the front, the baby boom. And then there was a big mountain of STIs during the 70s. You'll see on the left that syphilis didn't go up, but gonorrhea did. Why is that? Because gonorrhea becomes resistant to antibiotics, and this is a big story in itself. Syphilis doesn't. It's still susceptible to penicillin, almost uniquely for a bacterium. But gonorrhea has developed sequential resistance. It's not inevitable. Over the last few years, and this is a little told story because you hear the scare stories in the press, but the actual proportion of gonorrhea isolates in the US, the UK, and also in Belgium, of the 3 studies I've looked at, has actually gone down in the last few years, and that's because of very, very tight prescribing. Antibiotic resistance, like ARV resistance, is always caused by poor prescribing of suboptimal regimens. Remember that. Gonorrhea started going down again because I think we had for a while, clinics had a combination therapy for it of ceftriaxone and azithromycin. Recently, a decision was taken in the UK to drop the azithromycin, which I think was a mistake. I think we wouldn't dream of not giving combination therapy with HIV or TB or hepatitis C. Why do we still give sequential monotherapy of the latest antibiotic for other bacteria is beyond me. I don't know why we do it. Anyway, does starting PrEP increase STI risk? The raw figures suggest that it does have an independent effect of its own, despite all these increases. There was a meta-analysis of PrEP studies last year that suggested that, yes, it does. There was a 24% increase in the main 3 bacterial STIs after PrEP, in other words, in the 6 months after people started PrEP compared with the 6 months before, okay? And in one study, it was a really big increase. But only 2 out of 8 studies actually had significant increases. The big study is the study in Victoria State again in Australia, which was Australia has been a bit of a pioneer of PrEP. And we'll go into that. We'll look at it in more detail. Because this is a bit of a complicated slide, but I'll talk about it. This is a later study by the same author of the Australian, of the Victoria State PrEP study, or rather the successor to the same study. The blue and orange bars show that there was slight increases in STIs amongst people who had already started to take PrEP in other trials, okay? The green to red bars are the increases they saw in gay guys who were new to PrEP, and they look very significant. Look at that. That's almost a 50% increase of all STIs. Big increase not in syphilis so much, but in the other 2. But what was really happening? What was really happening was that it was almost all explained by higher rates of testing for STIs. And this is a big lesson. PrEP gets people into sexual health engagement, okay? So if you look at the columns on the left of the PrEP experience people, they're really, once you counted for testing rates, increased rates of testing, then the actual incidence rates of new STIs actually, went down in gonorrhea, for instance, and were pretty much the same in chlamydia. And increased a little bit in syphilis. The important thing is the PrEP naive guys. Now, the green is what the effect, if you account for the effect of testing. There was still some increase in the proportion of STIs, and a significant one in the case of chlamydia. But in the case of gonorrhea and in the case of syphilis, those became non-significant increases. In other words, the incidence was essentially the same. The increases that had been observed were due to more people coming forward for testing. Okay? All right. Another aspect of STI figures going up is because it depends what you look for. And this is a slide from the previous EMIS study, which found that actually a lot of STI testing in a number of European countries and cities is completely substandard in that they don't perform the kind of tests like anal swabs, which would find, for instance, gonorrhea in gay men. All they do is do blood tests for syphilis and perhaps do a throat swab, right? And as a result, you have widely different rates of STIs between European countries, which aren't actually real. They're about what are being tested for. And therefore, if STI services get better and more people get the right kind of tests, then you will see STI figures going up simply because they're finding them. So that's really important too. There has been computer modelling to suggest that if STIs were really well tested for and received immediate treatment, that they would start to go down, even in people who were having largely condomless sex because they were on PrEP. I'm not going to say anything more about that, only that I have a certain amount of scepticism about some models. But I haven't actually showed this, the extra, because I didn't put it on. There are experiments going on, for instance, in France, which are testing doing STI prophylaxis with antibiotics like doxycycline. The results I've seen so far suggest that that can work in chlamydia and syphilis. It doesn't seem to work in gonorrhea so much because it develops resistance, but it's one avenue that we're exploring about controlling STIs. And that is my lot. And thank you very much for letting me do my little bit of presentation. Please. And there's a picture from the last PrEP in Europe seminar.
Please wait with us, Gus. Any questions from the floor? Or did I frighten you into silence earlier? Valerie, would you like to make your way to the mic behind you?
Hi. Thank you, Gus. Great overview. Definitely will take it to PHE for their commentary. One thing to mention is clearly it's not just where you're testing across Europe, whether you're testing, but within each country when you're showing those rates. And you know this, and maybe you didn't make that point quite strongly enough, the modality of testing has changed so much over time as well, that it's actually really hard to look at trends, and similarly for HIV, as you know, and say, yes, it's going up or down, because testing patterns and what we're testing for and what we're using to test has also changed dramatically over that time. Thanks.
Thank you, Valerie. Off you go. Introduce yourself and your organization, please.
Hi, my name is Jarek. I work with Polish migrants in HIV prevention in London. I guess the question is probably based both on what Magda said as a barrier and what you said with the percentage raises because there's more testing. So is there actual numbers? How does PrEP increase amount of testing amongst communities? Does it work as a tool to increase awareness of sexual health if that makes sense?
Yes. I think this goes to the heart of one of the reasons we're doing this conference, because this is about PrEP as a catalyst, to use the title of the last series of presentations on Saturday afternoon. I think PrEP is an incentive to come into the STD clinic, you know? If you're a young gay guy, you are, I'm going to swear, shit scared of HIV, then you will certainly at least investigate PrEP, probably, as a possibility. And while you're at the STI clinic, the doctor or the nice nurse will talk to you and say, okay, so, you know, how's your sex life been? Oh, I've been doing this, that, and the other. Oh, okay, maybe we should screen you for STIs, you know. So it gets people into the system.
Thank you. I think we have one question from Facebook, do we? I'm actually going to Powermints down the aisle. Yanis, Facebook.
We have a question here from the Facebook stream. It's pertinent to an observation on increases in STIs in people who take PrEP and acknowledging that this is likely due to increase in engagement. What are your thoughts, Gus, on the move in California to not require prescriptions in order to get PrEP?
I only saw that a couple of days ago, and I believe it's a little bit more complicated than that. I don't know if somebody from the States like Sindra would know about it. I don't think it's like simply like buying an aspirin over the counter. Valerie?
It's only the first prescription for PrEP and PEP, I think, as well. And we'll do some you can answer this, okay?
So it's like not literally over the counter, I don't think.
So the pharmacist will give you PrEP without a prescription. They will give you a 60 tablets, and it's only for the first 2 months. After the first 2 months, you would need to go to the GP to get a prescription. For them to give you the medication the first time round, you would need to present the results of an HIV negative test. If you do not have that test, the pharmacists have to give you a test, and if it is positive, they have to link you to a network which provides HIV services.
Perfect. Neke? Okay, we're a little bit, these are discussion points, we'll deal with them in the debate, but let's hear your question.
Yeah, I have a question about, like, you talked about resistance to STI treatment, and I have a question that I'm from Ukraine. I'm working in public health, and we're afraid about resistance to TDF. If we spoke about PrEP, we're afraid that like huge scale up of PrEP will in future will do resistance that called like in 65 in genes. It's number 65 and number 70. It's resistance that can actually soon, like if we will have a scale up, we will have more that kind of resistance. And in the countries with, let's say, with economic, not so rich economically, we don't do a test for resistance. And if you don't have virological success with TDF, sometimes we change it to AZT. And if we change it to AZT and person on PrEP that actually didn't have perfect adherence with PrEP, will not have adherence to schema with AZT, it can be a way to do a resistance that's called MRAT, resistance like multi-resistance to all nucleoside inhibitors that are actually in all first schemas to treatment. So I'm asking about research about resistance to PrEP, and what do you think about future of resistance to PrEP if we have a huge scale up in different countries with different economic levels?
If you could answer that, Gus, and we'll take, because we've got time.
I think the answer to that one is don't mix up treatment with PrEP. They're very different things. Yes, the vast majority of antiretroviral drug resistance arises in people taking HIV treatment who already have the virus and have suboptimal adherence, okay? And they develop drug resistance as a result. They can then obviously pass it on if they have a detectable viral load, and so the second biggest amount of resistance is transmitted resistance. And I've seen models that suggest this. Only a tiny amount of ARV resistance in the world is likely to be caused by PrEP, because you have to be terribly unlucky. You have to have acute HIV and take suboptimal PrEP at the same time in order to develop resistance. Because if you take PrEP properly, you won't get the HIV, and if you get the HIV and you're not taking PrEP, you won't get resistant HIV. So that's how it happens. Also, K65R, even in people on treatment, is relatively rare compared with other resistance, other kinds of resistance. As for giving AZT PrEP, I very much hope you're not doing it, because you know, AZT nearly killed me, put it that way.
Okay, Gus, stay there. We're going to come back. We're going to come back to resistance in the debate. So far I've got TAF and I've got resistance. Those are for the discussion. Harriet, very quickly, one question. Very quickly, one answer, Gus.
I don't think it will be very quickly, but I will try. My name is Kirom. I'm from Tajikistan. It's a country in Central Asia. And I was curious about because it's more and more coming with the integration of the testing with HIV and STIs. Yes, it's more clinics, it's more open, and they're trying to combine all this testing system. But once you mentioned about introducing PrEP in the STI clinics or other clinics who are doing the same HIV and STI testing. I was curious about the cost effectiveness because not every country has the system with the insurance covering the testing. And I was I would mention about the Eastern Europe and Central Asia's country, which actually don't have money to cover all these testings.
Yeah.
And what do you think, how cost effective in terms of combining STIs and HIV testing, including the PrEP prescribing in STIs clinic or HIV clinics? Thank you. I don't know if it's the right question to you.
No, I can answer it.
But you presented all this data around the STIs in the UK and the US and other European countries. It would be good to know.
It's about answering it in a minute.
It's okay, answer it, but don't give us a monologue.
Absolutely, we need better surveillance of STIs in countries that aren't high-income Western countries. Absolutely, couldn't agree more. I think partially it's because we've had we've campaigned for lower drug prices, but we haven't campaigned for lower testing, diagnostic and clinic prices. And I think now we have generic ARVs, actually it's the clinic testing and diagnostic prices that are starting to be the barrier. This was even the case in the UK, where in the end it was getting the clinics to agree to pay for their extra staff time that was the biggest barrier in getting PrEP pushed through in the UK. So I absolutely agree. And the big global funders have to start thinking more about paying for proper diagnostics, i.e. viral load tests and HIV tests, and side effects tests and clinic time as much as they think about cheap ARVs.
Thank you very much, Gus. I think, round of applause.